Okay, so thank you very much for everybody to be here. As you see, I was cutting somebody just until a few minutes ago. The speech today, as for the last couple of years, is going to be Cranicervical Instability. But this time I'm going to give it a slightly different twist just to maintain the interest. As you see, there is a slight change in the affiliation. And these are the players which are involved in this problem. The first one is the box, which is the craniocervical junction. The second one is the content inside the box, which is the cervical medullary junction, is nervous system. The third one is the bubble wrap around the content inside the box, which is the cerebrospinal fluid. And whatever feeds the content inside the box are the vertebral arteries. So, some definitions. Craniocervical instability is a problem, a biomechanical problem, affecting the craniocervical junction, which is the box. The craniocervical junction is the complex joint between the skull and the spine, including the condyles, which is the base of the skull, C1 and C2. So here we can see the base of the skull, the first and the second vertebra as they are labeled, and the vertebral artery passing by, which are marked in red. These are in a section, and on the left, there is going to be the nose. On the back of the picture, there's going to be the back of the head. But in a cross section, going from the nose to the back of the head, you see the bones involved, and you see the ligaments, which are in yellow. The ligaments are the rubber band keeping the bones together. The cervical medullary junction is the region where the brainstem transitions into the spinal cord. So this is brain tissue going into spinal cord tissue. And on the left, you see a picture that you are used to see all the time, being Chiari malformation patients, so the cerebellum, the brainstem, and continuing into the spinal cord. Brainstem is quite complicated. The part which is involved here is the medulla oblongata. The medulla oblongata is an important bottleneck for the nervous system. The cervical medullary syndrome is the complex of symptoms, whatever you guys feel, and the signs, whatever an external observer can see, which are occurring whenever this area, which is the cervical medullary syndrome, the cervical medullary region, is affected. And that's regardless of the type of pathology involved. It can be trauma, it can be a tumor, it can be anything else. Chiari, craniocervical instability. Now, the cervical medullary syndrome, which are the symptoms and the signs, can be quite complex because there are a lot of cables passing by. And this is just a summary list of just the main chapters of all these symptoms. The pathophysiology is a complicated Greek term indicating and summarizing what are the mechanisms with which a pathology can cause the signs and symptoms of the cervical medullary syndrome. So you can have three things. You can have a mechanical compression or distortion of the nervous tissue. You can have a vascular compression leading to the nerve tissue not having enough blood, or you can have a disturbance of the flow circulation of the CSF. So this is normal anatomy, and this is abnormal. You see already that there is a big difference between this and this. So there is the top of C2, which is kicked backwards and is compressing the brainstem. In this case, these are the normal arteries seen from behind, and these arteries can be pinched if the skull is too close to the first vertebra. On the other hand, being old Chiari experts to a point, you understand that the CSF, which is the bubble wrap around the nervous tissue, and also kind of a lubricant for the nervous tissue, requires, in order to be working properly, to circulate around. And, whenever there is a blockage, there are problems. Now, what are the pathologies? What are the disease processes which are causing the cervical medullary syndrome? There are many: trauma, tumors, inflammatory processes, infections, congenital malformations, and so on. There are, despite the fact that the list is long, they do not behave in the same way. Certain pathologies like traumas and vascular events, like a stroke. They're harsh and they're fast. The tumors are slower and they keep going. They're progressive. But some pathologies are even slower than a tumor, and they will keep going like on simmer. So the way that these pathologies present in time and in space gives, helps giving within the spectrum of the cervicomedullary syndrome, helps giving different clinical presentations. So what are the pathologies, the craniocervical junction? Because this is the focus for in the context of the craniocervical instability. The problems can be static or can be dynamic. And for example, the congenital anomalies, something you're born with, they're quite static and they're self-evident. Self-evident means that they pass the medical student test. So when there is this normal anatomy and a medical student sees something like this, he's saying there is something wrong there. So you don't have to be a super specialist, you don't even have to be a neurosurgeon to understand that there is something problematic and the junction between the brainstem and the spinal cord gets deformed, and by being deformed, gets in a position of not working well anymore. Now, the craniocervical instability can also be caused by traumas, infections, inflammatory processes, and degenerative diseases, and these processes, they can affect both the structure and the mechanics, so they can be static and dynamic together. So you have a leaning tower of Pisa, which keeps going down and down and down over a course of months and weeks. So these are two, processes. One is on the left, you can see a big tumor, which comes from the base of the skull, and you see how much the brainstem and the cerebellum are pushed all the way in a corner. And that one on the right is an example of a massive trauma in which the only thing keeping the head attached to the neck are just muscles and skin. There can be a complete dissociation of the joint, and this is called internal decapitation. So these pathologies are obviously very self-evident and they pass the medical student test. Now, the craniocervical instability can also be caused by dynamic problems which affect the ligaments. So everything which affects these rubber bands which keep the joint together can lead to craniocervical junction, even if all the other pieces, the bones, etc., they are completely intact and they look normal. So again, in blue, you see the ligaments, and their arrangement in space is quite complex for a craniocervical joint. This is the normal anatomy, and this is a abnormal anatomy in case of ligamental laxity. As you see, there is not a lot of difference, so this does not pass the medical student test. But the patient over here doesn't have symptoms. The patient here has a lot of symptoms. So a number of works have been done over the years. This is our first article from 2007, a recent from 2019 by a larger group. And one of the most common problems at the base of this dynamic presentation affecting ligament is the Ehlers-Danlos syndrome, which is one of the diseases with connective tissue, is actually the most popular. The reality is that most of the patients coming to neurosurgical attention, they actually have a more complex form, which is sort of a salad bowl in which Ehlers-Danlos is, is the roughage, and then they also have other components from other diseases. But just to keep it simple, let's call it Ehlers-Danlos. Now, how do we make the diagnosis in this case, since the anatomy is less than obvious, and they do not pass the medical student test? The craniocervical junction can be analyzed by about 20 measurements, and many of them were designed for trauma and for x-rays and for after trauma back in the 50s. So many were built for static malformations. So very early, about 20 years ago, we started working on this. And we narrowed down to 3/4 of these measurements, which are the PBC2, the CXA, the BDI, and less known by many of you, the BAI. Again, these measurements were already born, some of them earlier, some of them later, for trauma. Now, there are three components of the craniocervical junction function and the relative instability. So one is the horizontal plane, one is the rotational direction, one is the vertical. So in severe cases, all three can be affected, but in less than severe cases, one or two of them can be affected. So this is what needs to be known. Not all these 3/4 parameters that we use for craniocervical instability for connective tissue disorders work the same. And they work from different perspectives. For example, the first two, they are good to identify something which is wrong in the horizontal plane. But the BDI, which is the basal dense interval, if used dynamically, is the best and actually the only one to identify vertical instability, which is with an old term identified with the term cranial settling. So this is an example of just the CXA and the PBC2, aka the grab. Practically all of you know this. And this is the breakdown for the BDI and the BAI. Now, the second line on the top is indicating the rule of 12. The rule of 12 is a rule which applies only to trauma. And here comes the point. In many patients with craniocervical instability, you can find patients violating the rule of 12, so therefore passing already in abnormal territory, and some of these patients have no symptoms. Now, this probably is the most important slide on the entire presentation from my perspective. Do not play doctor. I see a lot of patients, and I hear about a lot of patients on social media and on, whatever you have, measuring each other's MRI and reaching conclusion and giving suggestions about what the pathology, what needs to be done before even the poor next newbie knows what hit them. Now, why you don't have to play doctor? Obviously, the obvious thing is that you didn't study enough, but measuring correctly these measurements is not easy. And just a small error of small error of just 1 millimeter can make the difference between normal and abnormal measurements. The other warning is that there are no normal values, there are no normal ranges for EDS. And that's a major problem. All the normal ranges for which we use use parameters have been already established for X-rays, for trauma. But there is no big studies so far defining what is the normal range for EDS patients, and especially if we include the ligaments and we do the MRI measurements. So that's a big problem. But the two major issues that I put underline and in bold are the following. You can have abnormal measurements in normal people, and vice versa. You can have very sick people having normal measurements at baseline. Example that I like to make all the time. If you go at the Olympics and you do an MRI on all the people who are participating in gymnastics for the US Olympics team, they're going to have, first of all of them have connective tissue disorder, otherwise they would not be participating at that level. And all of them will have colossally abnormal measurements. And for sure, we cannot tell them they're sick because not only they're normal, they're doing things which are superhuman. So you cannot rely, and vice versa, you can have sick people who have normal measurements. Then, the thing changes if you do dynamic testing. And by the way, if somebody raised the hand saying that the flexion extension MRI is that dynamic testing is going to be wrong 2/3 of the time. So for this reason, you cannot base your judgment, and nobody should, not even doctors, on measurements alone. So diagnostic criteria, when do you make the diagnosis of craniocervical instability? Obviously, straightforward cases which pass the medical student test are just obvious, and this case closed. The problem is for everything else. For everything else, not only is difficult, but is also controversial at some point. For example, in Dr. Mirat, myself, and Dr. Francomano were the first one talking about and then writing about craniocervical instability and EDS. Many people did not believe it at all. We were pretty much alone in the very beginning. And it took about 10 years for this to become not mainstream, but to become more popular among some specialists, to the point that, in many Chiari meetings, nationally and internationally, there is an EDS, craniocervical instability section. But it's going to take probably 10 or 15 years before it becomes really mainstream in neurosurgery. So for everything else, which does not pass the medical student test, every specialist has his or her is just to be like Me Too oriented. So far, there are no women who are in this field. But every specialty has his own recipe. So, and this is my recipe. And by the way, this recipe is not the recipe I had 5 years ago. It's not the recipe that Dr. Mirat and I started with. But this is part one, this is part two. What is without going into details, what is the point? The point is we do not rely on imaging alone. And I hate this word, but we consider the patient holistically as a whole. So we get all the pieces of information we get, and then at the end we reach a conclusion, and then we verify it with invasive cervical traction. And we make clinical and radiological assessment at the beginning and at the end of the traction. Now, invasive cervical traction, not many people use it, but I have a number of colleagues that once they started using it, they did not stop. And invasive cervical traction has some values, and I'm in the process of writing an article about it, so I'm not going to bore you, but it's a sort of a Supreme Court test to verify whether or not your running hypothesis of craniocervical instability for an individual patient is correct. So here you see this medieval device with which the patient, the outside layers of the skull are pierced by these two screws, which are connected by a bar, which is connected to a rope and a system of pulleys and weights. Using one thing in common among all these three girls, they are all smiling, because at the level of that traction and traction weights, all their symptoms are either improved by 80 or 90%, or they're frankly gone. So during the test, for each symptom that is present that day, we ask for each level of poundage of traction. We ask them how much the symptoms improve from the baseline. At the beginning and the end of the traction, we measure the 3 or 4 parameters we talked about. Once they pass a certain threshold, for example, the BDI here of traction was 3.7, and if it changes more than 2 millimeters, that's a sign of cranial settling. In this case, it changed by 4 millimeters, and all the symptoms were, as you see, very much improved at 30 pounds. So at that point, we have confirmation the patient's instability and is in the face of the compromised quality of life and other factors, she was surgical grade. Now, the decision tree about the therapy does not go for surgery automatically. Mild and moderate cases, either you do nothing or you stick to the conservative management. Severe elective cases are the cases in which you give the patient the option, because if you do not do the surgery, the patient is not going to die or is not going to have a progressive neurological deficit. And you have to explain what's the pros and cons of the surgery. Obviously, conservative management and surgery are not equivalent. Conservative management, the very best, in these severe elective cases allows you to tread water, but doesn't make you better systematically. Surgery in good hands has more than 80-85% chances to improve permanently your quality of life. Severe urgent are the cases in which the patient is really going downhill fast. And if you do not do surgery, it's going to be a bad idea. So you have to lock the door until the patient is convinced that he's going to go ahead. The surgery, there are many different approaches, which depend on what the patient has. I'm not going to bore you on that. But one major dilemma is the field of complex Chiari, because the Chiari surgery wants to remove bone in the same place where the cranial-cervical fusion would like to put screws and add bone. So this leads to different kind of technical approaches and technical ways with which people approach this case, this problematic. This, there are different ways to do cranial-cervical fusion. This is the conventional one. Few other people can do the condylar screws. The important thing is that something is better than nothing. And other messages, the condylar screws they're difficult to do, and they have a steep learning process. So I do not recommend it to people who have done just a few in their career. Now, what has kind of changed our opinion recently is that we identify new and formerly, we were unaware of these cranial-cervical instability patterns. Now, we knew about something called Grisel syndrome, which is something which happens in kids when they have ear or nose infections, and the infection through a venous network can affect the cranial-cervical junction. Okay, we knew it, but we did not know, for example, that systemic infection like Rocky Mountain spotted fever or certain tropical infections like Giardia and other things that you catch whenever a white man goes in where he doesn't belong, like in the middle of the tropical forest. I've seen many people who did not have EDS becoming unstable after an infection. I saw there are people having a recognized diagnosis of mast cell activation disorder, developing cranial-cervical instability because the products coming from the mast cells can actually tenderize, like beating a steak, the ligaments. I did not know that, and now I find them more and more. Prolonged allergic reactions or infections can actually precipitate mast cell, which by the tenderizing effect can cause cranial-cervical instability. And all these three mechanisms can occur both in EDS patients who already had EDS to begin with, and this I was not aware until I started looking at the different cohort of patients, can actually generate instability of the joints in people who are not EDS to begin with. We have two studies going on, and I'm almost finished. One is a retrospective IRB study for our experience. We had 20 years of experience, almost 1,000, actually we passed 1,000 recently, cranial-cervical fusions. More than 300 are done with the condylar screws, most of them EDS, and many of them complex Chiari-1 malformation with the terminology of Dr. Brockmeyer. We were calling them Chiari Plus in the past, but anyway, whenever you have Chiari-1 malformation and cranial-cervical instability, that's called complex Chiari now. Then the second IRB study, which is going to start in August, is going to be prospective. Prospective is sort of a higher level of scientific investigation. And instead of looking backwards, you set certain parameters and then you apply it to a certain population. So it's a more rigid study. So far that I know, there's been no prospective studies for the instability in EDS population. And we're doing it at this current hospital. And the interesting part is that we're going to do harvesting of tissues, and we're going to send it to the Harvard Brain Tissue Resource Center. We're going to have two study groups from Harvard and one from Stanford who are going to participate in this. And they're going to make analysis out of the tissues we're going to harvest. So what is the bottom line? The bottom line is that cranial-cervical instability is a wide umbrella. Obviously, you guys as Chiari One Malformation have heard more about EDS and complex Chiari, but I want you to be aware there is much more than that. The second thing is I do not want you to play doctor, because the imaging by itself is not enough to reach the diagnosis. There is a growing amount of doctors who are becoming familiar with these problems, which are also dynamic, and it's a field which is rapidly expanding so far. So thank you very much, and I'm done with my contribution and look forward for the roundtable.